What I think is really one of the most important things to improving outcomes with patients with gliomas in general is to really apply all of the things that we've learned over the past 10 to 20 years in terms of the biology of these tumors, and specifically the molecular subtypes and genetic subtypes of these tumors into the clinic, both in clinical practice and clinical trials. Again, I don't think glioblastoma is one cancer. Glioblastoma is at least several cancers, probably 4 different, very distinct molecular and genetic subtypes. And you really have to study each one of these molecular subtypes in the lab individually. It's distinct from each other. Treat these patients distinctly. Each one of these molecular subtypes very likely should be treated very differently. And on the other hand, if you're going to investigate the efficacy of your drug, you really have to test your therapy, whether it's immunotherapy, drug therapy, surgical therapy, on each individual molecular subtype, because if really you test it on all glioblastoma, what you really have is a mixed bag of tumors. Some patients are going to do well, some patients won't, and you really are not going to get a true sense of whether or not your therapy is working or not. I think it's one of the things that the field of glioblastoma is lagging behind on. We haven't stratified patients enough for patient management, clinical care, nor clinical trials. And once we start doing that, that's the first step. So certainly novel immunotherapies, novel targeted therapies might come about, but unless you test them in the right populations, it'll be very difficult to assess whether or not there's going to be efficacy or not. On the other hand, because of all this heterogeneity within what we call glioblastoma, some people will likely be even overtreated potentially, meaning exposed unnecessarily to toxicity, and maybe even suffer from that toxicity, maybe even potentially die from that toxicity, when perhaps that particular molecular subtype, because they had a certain molecular subtype that might have responded to standard therapy or done well in general, they didn't need to be exposed to so much toxicity. So that's one of the first major steps I think we need to take as a field to improve outcomes in patients with glioblastoma. The other thing I think that we need to really do that we're not doing enough as a field is take other factors aside from survival into account. So what we're doing with patients with glioblastoma is not just giving them chemotherapy, but we're doing surgery to take out part of their brain many times, and then radiating their brain. And what we look at then as outcome is the tumor coming back or how long the patients live. But we don't do enough is what is the quality of that survival. Some patients do extremely well with that multimodality therapy, and some patients really do not. Some people get severe cognitive impairment, motor impairment from the treatments that we do, and some of the treatments that we are doing directed at their brain. So the other major thing that we really need to focus on as a field and to improve the outcomes of these patients is to start looking at measures like not just quality of life, but neuropsychological measures, neurocognitive measures, and see the things that we are doing. Are we really improving the quality of their life or sustaining good quality of life, no matter how long they live? Because that's so critical for these patients. And then on the other hand, yes, we do need better drugs, better radiation, better surgical therapies to extend the lives of these patients, because at the end of the day, we really haven't made much progress in the past 50 to 90 years, really. We've just made small incremental improvements in the survival of these patients. We need newer therapies. And I think immunotherapy is very promising, but the current iteration of immunotherapy right now remains to be seen how much of an impact we're going to make in patient survival. I do think that some of these combinations hopefully will be successful. It remains to be seen which one of these combinations, but I do think that eventually we'll get there. But again, we do need better therapies.